Right. So, hello, welcome back. So, for our final panel presentation for the day, Implementing for Success, our panelists will explore how to overcome challenges to the successful implementation of equity enhancing design features, including regulatory restrictions, IT systems limitations, and data availability challenges. Going to span the gamut. So, our session will be moderated by Orriel Richardson from Morgan Health, and our panelists include Lina Rashid from CMS Sasayo, Tamara Ward from Oscar, Mila Kofman from the DC Health Benefit Exchange, and Dr. Irene Dankwa-Mullan from Marti Health. I'll turn it over to Orriel.
Good afternoon, everyone. Based on what I can tell, the day has been full and robust, and the description of this panel has a lot of words that could seem to be a little bit droll at this point in the day, but I promise you the conversation that this lovely panel of women will have is going to be enlightening and a good way to end the day. So, all day long, there's been a conversation really focusing on employers, and if I had to hedge my bets, it would be heavily skewed towards the larger employers. And so the interesting thing about this panel is we have some representation from the parts of Insuranceville that really also touch the medium-sized and smaller businesses. And also beyond that, we have some different perspectives from outside of the pure sort of insurance world. So we're hoping that as we get into the questions, each of the panelists will do us the honor of sharing a little bit more about themselves and how their organization centers health equity as a goal as they answer the questions. So, Mila, let's start with you. As the executive director of the District of Columbia's HealthLink, the insurance marketplace, you've implemented benefit design changes to address disparities. So, can you talk a little bit about what you did, whether there were implementation challenges that you had to overcome, and also how you hope to measure success of your efforts?
Yes, yes, and yes. Thank you. And I'll say thank you to those of you who are still left in the room. It's nice to see all of you still here, so thank you. And I'd just like to start by saying thank you to the Academy for hosting this and continuing to have this conversation about how do we address differences in health outcomes, health disparities. How do we get us all onto the journey of equity, of health equity? So thank you for having this conversation. Thank you for inviting us. So some of you are wondering, why is the Affordable Care Act online health insurance marketplace from DC, executive director, is even here, right? I know you are. So here, we are new to the journey of health equity. For many years, in fact, we just celebrated 10 years of being in business. We opened October 1, 2013, which I measure in doggy years. We've always focused on getting people covered and helping them stay covered, right? So, like many of you, a few years ago, we watched the murder of George Floyd. And like many of you, we saw COVID data coming in. Who was being hospitalized? Who was dying, right? And so those two events caused us all, my board and my team and myself, to just pause. And we really wanted to, in our lifetime, be part of the solution, to figure out what we can do with the authority we have to make a difference. Recognizing there's no way we're going to give you clean air, clean water, housing security, food security. We're not going to address political determinants of health. And I've heard the word social determinants. I actually think it's all political. So I call it political determinants of health, right? We're not going to address that. We cannot help you with that. But what can we do? So my executive board established a social justice and Health Disparities Working Group. And on our working group, we had all of our partners. We had all our health plans, the hospitals, physicians, consumer advocates, brokers, and experts. And we were trying to figure out and to understand, what can we do? What can we directly control, or what can we affect positive change in? And so, and my board chair was the chairperson for that working group. And the working group came up with very important consensus-based recommendations that we are now implementing. And if there's time, I'll share some of the other efforts in addition to equity-based benefit design. We're also engaged in understanding clinical algorithms that are racist and continue to perpetuate differences in health outcomes. We're also looking at understanding not only the clinical side of it, but working with our health plans, understanding what processes they have that may lead to differences in outcomes. And some of the earlier speakers talked about pre-authorization. For example, does pre-authorization apply to conditions that disproportionately impact communities of color, right? Those are all the questions we have to understand and ask, as well as how our care gets delivered. So I definitely want to talk about that. But right now, you've asked me to talk about our equity-based benefit design. So our working group looked at conditions that disproportionately impact communities of color in DC. And we started with type 2 diabetes. So for us, equity-based benefit design means acknowledging that cost is a factor. It's not gonna, addressing cost, by the way, is not gonna address systemic racism everywhere. But it's one part of the answer to serve one part of the community we serve. So we wanted to eliminate cost as a barrier, and in DC, for example, twice as many Hispanics report cost being a barrier to going to a doctor, for example, twice as many as white residents. So we know cost is a barrier for some of our residents and employers and their workers. So type 2 diabetes, we said insulin, no cost to you, the patient. Your annual foot and eye exams, no cost to you. The lab work you need for your type 2 diabetes, no cost to you. If you need other medication in addition to insulin for your type 2 diabetes, no cost to you. So in using words that I'm not supposed to use, according to Dr. Lisa, no co-insurance, no deductibles, no co-payments. So when I talk about it to the folks we serve, I just say it's no cost to you, the patient, it's free. And that's important. So that's one element of our equity-based benefit design. And all of our standard plans now have equity-based benefit design. Starting January 1 of 2024, we've reduced the cost of pediatric mental health. And we did that because we are at risk of losing an entire generation of Black and brown children in DC. COVID isolation, vicarious trauma, the list goes on and on. So we wanted to eliminate the cost barrier for those parents who have children who need mental health services. For outpatient services, it's just going to be $5. As many visits as you need to the psychiatrist, psychologist, other specialists that your kid may need to see for mental health and behavioral health. Medication your kid needs, $5. Lab work that your kid needs because he, she, they are taking medication, $5. So that's an important feature. And right now, we're also working on looking at heart disease, including high blood pressure. So cardiovascular, words I'm not supposed to use, and hypertension. I use them here because there's so many actuaries, and you would not pay attention to me unless I used long words. So right now, thank you, Dr. Lisa. So right now, we're working on adding additional benefits, equity-based benefit design, to our standard plans. But our biggest barrier is the AV calculator. And so I know we'll have time to talk about how we've tried to address it. And I certainly appreciate the federal help that we've been getting from Lina and her team on that.
Well, that's quite a way to start. There's a lot to unpack there. And as we go through the conversation, where possible, I'll also try to impart some source material for those who may be seeking some. So you referenced Political Determinants of Health. Daniel Dawes is the scholar who's responsible for coining that terminology, and it's an excellent book that I think should be required reading for anyone who's on a journey towards health equity. You also mentioned clinical decision support tools and the misuse of those. Dr. Michelle Morse, who is the Chief Health Equity Officer for the City of New York, helped to initiate that work and continues to do so from her vantage point there, and helped to write a report on that when she was a fellow with the Committee on Ways and Means, so that is available online as well. And also, I think the interesting thing, not to be provocative, but thinking about the demographics of the District of Columbia, thinking about how up until, let's say 5 years ago, it was heavily skewed majority Black population. And we still have this conversation about health equity being something that became important front and center circa 2020. So I'm curious, even when you think about all of the opportunities for DC to have excelled, and I say this being an alum of the District of Columbia Department of Healthcare Finance myself, I'm curious, Lina, from the vantage point of the federal government, how has health equity and the conversation around advancing it from SOCIO's vantage point, how has it evolved over time, but including the events of 2020 that Mila referenced?
Hi, everyone. Let me see how I can get this to work. Okay. Try it. Hello? Yes. Oh, there we go. Thank you. Great. Hi, everyone. My name is Lina Rashid. I'm a senior advisor over at SOCIO. Before I started, the young woman asked me, can you tell me what that acronym stands for? And I was like, don't worry, I'll talk about it. So we are a part of CMS, and our acronym stands for Center for Consumer Information and Insurance Oversight. We are focused on implementing the Affordable Care Act, specifically provisions related to the private insurance market. We also enforce the Public Health Service Act, which kind of works alongside our colleagues in Treasury and Labor. And we also implement the No Surprises Act. So that's kind of the breadth of the work today. And I focus on policy and operational issues and health equity issues. So I think I'll start with kind of where we are today and kind of delve later in terms of how we've evolved. But I think you heard from other folks at HHS, and equity is a key part of the work at our agency, and it's spilled over into SOCIO's works as well. So I would kind of bucket our work into 4 categories and 4 main goals. The first is to increase coverage among underserved individuals. The second is make it accessible to underserved communities and strengthen the consumer protections that people have and improve data collection. So we kind of have those 4 major buckets, which we have used in this administration to kind of guide our work forward. And so one of the things I'll talk about is open enrollment. We are very excited about open enrollment. I'm sure Mila is very excited about open enrollment. This is our 11th year, and we're really excited about the people we've enrolled so far and continuing that growth moving forward. We have 16 million people enrolled in coverage, 16.3. We like to count every single person that we did enroll. And we have seen that we have increased the rates of insurance in underserved communities, but we still always have more work to do. I want to highlight that we've increased the rates for Black consumers by 49%, Latino consumers by 53%, and American Indians and Alaska Natives by 32% when we compared between 2020 and 2022. In that sense, I do also want to highlight that our population and demographics changing. We've seen almost 20% of new enrollees are those who are non-citizens. So we're definitely seeing that there's outreach to these communities happening. We are seeing a substantial investment from the agent and broker community to really enroll people, and we're very excited about those efforts as well, and also kind of our direct enrollment partners. And what we want to emphasize from a partnership perspective, there's many folks in the room through issuers and community organizations and actuaries are helping people price their plans that are all kind of working to that goal, and we really see this as a teamwork effort. We are continue to be excited about the affordability improvements that we have in place from the Inflation Reduction Act, without which I don't think we'd have great products to really offer folks. And so 4 out of 5 enrollees can still get a plan for $10 or less, which is something that we continue to be excited about. We have quadrupled our number of navigators. I know there was some talk here about community investments, and those are really targeted at our underserved communities, and we have about $95 million that we have invested in this effort throughout states that are on the federal platform. We also, for this open enrollment, launched a new pilot through our Enrollment Assister program, and it's about a $5 million investment in kind of mobile assister platforms, so kind of really focusing on reaching underserved communities and the like, and it's something we're testing out, and we're hopeful to see how it works and more in the future. And we continue to do a lot of outreach through our investments in advertising and the like, which we think will be critically important for this open enrollment, and particularly as people are winding off of their Medicaid program, which I'll talk about in a second. This open enrollment, we are also for the first time launching 3 new optional demographic questions about sexual orientation and gender identity. And so we're excited about this and kind of our data collection efforts. This is the first time we've done it. This is still voluntary, but we're excited about having this information and finally being able to collect some information in this exchange. And I mentioned unwinding earlier, we also have a special enrollment period. So for those individuals that are coming off of their Medicaid plan, looking for coverage, there'll be an opportunity for them to enroll in coverage through July 31st. We have seen some numbers so far, which are promising. Under 500,000 people have enrolled between April and July, made plan selections, over 100,000 or so in SBEs. We do think that number is undercounted, but it's kind of a significant investment and very key to kind of our equity efforts for helping underserved communities. So in the access front, I'm going to be broad because I think we're going to talk a little bit about network adequacy later, but we have made improvements for wait times and time and distance standards that we'll talk about a little later. We have focused on our essential community providers and making sure the network and amounts are increased, so we increased that in some of our rulemaking. We have focused on data collection. So I mentioned kind of the SOGI efforts. We have also we were collecting data from issuers in our claims data in the individual market. We've expanded that to individual and group market. And we are starting kind of in a graduated realm from 2023 to 2025 to start collecting information on race, ethnicity, zip code, whether someone's getting a state subsidy, whether they have a QSERA, and the like, and kind of collecting this data, which will really help us for our internal efforts and evaluation efforts. And then one area we've continued to work on, and I will say we still struggle with, is just collecting voluntary race and ethnicity data from individuals so that we have a better sense of who our demographic is in our marketplace. We have tried various things. We have made some improvements to our application to have some help text to help consumers understand that this is not used for the eligibility, that this is not going to be shared with anyone. We've tried to educate our assisters and our agents and brokers in our community to educate other folks as well. We have tried to increase our kind of content in different languages. And we've seen some successes in state-based exchanges that we can talk about a little bit later, and some things that our web brokers have tried, and I think an area that we continue to want to do more community engagement. And I think marketplaces maybe a little behind Medicare and Medicaid, but not that far off. I think it's kind of a consistent problem across all of our Ms. And then we are continuing to kind of work on our No Surprises Act provisions, which note that you can't charge more for out-of-network for non-emergency care. And some of you might be familiar with Section 1557, which is out of our Office of Civil Rights, which talks about discrimination on the basis of gender identity and sexual orientation. Another program close to my heart that I work on is Section 1332 waivers. And I get to work with a lot of actuaries as states are kind of working on that side of it. So do want to highlight states that have done innovative things in that realm. So Colorado is a state that has offered subsidies for the subsidized and unsubsidized communities, and they're offering care to individuals without legal status with subsidies as part of their Section 1332 waiver. So we're providing funding for that effort, and they are providing a Colorado option plan with targets that help reduce premiums overall in the market. And we have Washington State, who worked with us on a waiver to kind of expand coverage to undocumented individuals as well. We've also seen in Colorado that they've added gender-affirming care as part of their essential health benefit. So we've seen some state innovation as well, and we look at ourselves as federal partners to kind of spur that innovation. So I would say to your question of like, how has it changed? I think getting people covered and making coverage affordable has been a goal of the Affordable Care Act. It's been a goal of the agency. But I think what I think CSIO has done is made it a part of our strategic vision and our strategic plan and a part of our resources in terms of how we invest our time in rulemaking, increasing our investments in stakeholder engagement for underserved communities. I think you can have those same goals, but I think we're implementing it in a much more targeted way than we have before, which is something I hope we continue.
Excellent, thank you. So I guess at this point, we're going to move a little bit from the macro to the micro and get to first, Dr. Irene. I'm using first names. I hope we're all friends here. And I think the sort of interesting part about what your organization does, and I'll let you tell it, is you get to focus a little bit. And so I'm interested if you wouldn't mind, between your perspective with your clinical background and how you understand data, I'd love for you to share some of your insights and experiences on how we can use the data that are available now, particularly picking up on some of Lina's comments around struggles with collecting race and ethnicity data on a voluntary basis, and then the suggestions that you may have in order for us to figure out ways to glean and collect better data.
Well, first of all, thank you for the invitation. And I do want to answer this question not only from a clinician perspective, but also as a researcher and scientist. I've worked 8 years at the National Institutes of Health as a physician and researcher focused on health disparity science, trying to advance the science. And then I spent another 8 years in big tech at IBM Watson Health as the Chief Health Equity Officer. And so I've really been engaged in scientific data around health disparities, data that is being used in technology, in machine learning and artificial intelligence. And getting race and ethnicity data, especially inclusive race ethnicity data, is really, really important. We are basically in the era of precision medicine, right? We're moving away from the one-size-fits-all medicine, where historically we've basically based our science evidence on homogeneous populations, right? And our evidence has not been inclusive. And so, precision medicine is an innovative approach that was launched just to incorporate our unique differences in exposures, in our, in race, racism, ethnicity, so that we can better understand the disparities in our health outcomes, disparities in access to care, and incorporate all that so that we can move towards personalized precision care. Without race and ethnicity data or these categories or social determinants and other cultural factors in our data, we will not be able to provide that precision care or personalized medicine era that we're moving into. And so it's really, really important. I currently, first of all, let me make this advice in a way that's humanly as possible. I want to say that given this era of digital transformation and data, the era of big data and AI, each one of us, our organizations, our businesses, need to know our data as thoroughly as possible. We need to really have, we should not be in a position where we're trying to figure it out and we don't know where to start. I think we're somewhere, we're starting to get race and ethnicity data, but we need to have more inclusive data. We need to go beyond just race and include sort of country of origin and culture, because our science evidence is flawed because of that. Our algorithms in AI that we're building is biased because of that. And I think it starts with all of us. And so that's one reason, one point I'll talk about. I want to share, you asked about, how can we use the data that's available or suggestions? And I would say that, the data that we have available is not comprehensive enough to move towards this era of precision medicine, unfortunately. And so, in the previous panel, we heard about using zip code. We heard about using, really looking at basically social needs. And I think we could start from there. Let's standardize social determinants data. Let's include sexual orientation, gender identity. Let's go beyond race and let patients or our members or our beneficiaries tell us, how they want us to describe them. And so there are few ways in which suggestions, of course. Let's also start incorporating the, patient-reported outcomes. Include them in our, design, have surveys out there to better understand how we can collect data, engage communities. I know I'm preaching to, a lot of us are doing it, but I think finding a way of doing it better, getting that inclusive data is the only way it would move us towards catch up with precision medicine. Otherwise, we're using the same homogeneous data that is really not helping us, but causing, exacerbating the existing disparities that we see. So.
Okay, this is a great. Now we're going to be introduced to Tamara. Tamara. You got it. Tamara. Okay. I think the interesting thing about what Dr. Irene is saying is it really is talking about this large problem in a lot of facets of our society. The reference man being the marker for health services research until I think last year when they developed the standards for a reference woman to actually be incorporated into how our health services research does the basic research needed to inform our interventions and cures and such. And so even thinking about standardization of data, it almost seems to be in dissonance with being flexible enough to receive how people see, perceive, and want themselves described and reported. And we really have to, figure out how to grapple with that tension. But I am encouraged personally by this advent of AI and machine learning if we can figure out how to adjust for some of the biases that those tools would be subject to as well. But shifting over to, I wouldn't say it's a startup anymore, but let's say it's a more innovative way of doing health, Oscar Health. Tam, can you talk about in your role where you oversee implementation of new benefit and health equity initiatives, what are some of the challenges that you've seen in trying to achieve your goals and even thinking about needing to ingest data from different sources and vendors and all of the lack of standardization that you have to accommodate in terms of trying to get those operations such that Oscar can do what it does for patients?
Absolutely. Great question. Thank you. And thank you all for having me here. I lead our business strategy and operations at Oscar. And, I'd say probably about maybe 3 years ago, when we all watched George Floyd's murder on TV, I felt compelled as an African-American leader within our organization to do something. I had just joined Oscar. We were one of the first healthcare technology companies started by leaders who had no healthcare experience. And I was joining the organization with maybe close to 15 years of experience. And there were a lot of folks on our team that were also equally just mentally impacted by what they saw. And we decided that we were extremely positioned well to do something about it and build something sustainable beyond just the ACA insurance in which we were focusing on, that we believed could help in addressing healthcare disparities, which was the birth of culturally competent care. And the original vision of that was to take the technology that we built to help with member experience, to help understand the consumer in a more innovative way, and couple that with our provider networks, while also having what I consider to be this very hard discipline of continuous learning and innovation. And the way our technology is built today, it's one of the only full stack technology claim platforms that is highly customizable. And so if today we need to address the challenges that are faced with our Spanish-speaking population, and we understand that they have higher propensity for diabetes, we can quickly adjust our system to provide innovative benefits to remove that immediate barrier to them seeing a nephrologist or the right care provider for their care. And as we developed culturally competent care, we realized that we wanted this to be more than just a program or initiative that was exciting for that point in time, but more so about how we run our business and how do we deploy personalized and individualized care. So when you talk about precision medicine, I view that as our version on the health insurance side. How do we meet our members where they are? How do we service their needs based on where they are, whether it's their socioeconomic status, their demographics, you name it. And so over the past few years, we've worked on collecting that data. We first started with collecting our member data. We have about 75 to 80% race and ethnicity data on a majority of our population. We have roughly over 1 million members across close to 20 states, and 90+% of our business sits in the affordable exchange. And so a population that most would say would be typically pretty difficult to collect information from. However, our tools have been relatable, as the panelists spoke earlier, so that our members believe that their engagement with their health insurer is actually one worth their time. And as we thought about, pulling all of the data in for our members, we started to say we can do a lot with tech. We can engage our members through email. We have the ability to engage them directly through our app. We can engage them through SMS text messaging, but we're not going to be able to meet them every single place in which they are. We have to figure out how we use our technology to also make a meaningful connection with their providers and the provider community. And so we went on a path to really better understand how we can ingest information from our physician community to better understand what physicians within our network had culturally competent training, that were culturally sensitive to the various different demographics of our membership population. We knew based on surveys that we conducted from our members that they wanted to be seen, some of them, not all, by physicians that looked like them, because there was a mistrust in the system from their perspective. And if there was someone, whether it's from their community or from a different race, an ethnic background, they'd be more likely to listen. And so as we started to unpack that, we realized that not many physicians actually report that information. We started to see various disparities at even the state level from regulators that even require that information to be shared. And in markets where we did have access to the data, we were able to do a really great job of creating access. I recall a pilot that we ran down in the Houston market of connecting with Black female members with African American providers in the community, and our ability to retain that membership by creating that connection. Another pilot we ran, we realized in certain markets that we had gaps in our Black maternal care for our African American members, and we partnered with a virtual OBGYN practice to help close that gap. And so when we have the data, it allows us to really innovate in a more meaningful and positive way. I know we started this conversation around getting standardization around the data. I would argue that that is a really hard challenge and a hard case to solve. We've built technology that allows us to ingest data from anywhere. And so my bigger ask would be just share the data, and we will figure out how to analyze it and how to ingest it in our systems. I think last but not least, one of the key barriers that we see to being able to continue to implement a lot of these health equity focused plans and products is really our limits on plan and benefit design. We spoke a lot earlier about not solving for the masses, not creating products for the masses, not creating solutions for the masses, not assuming that broad provider networks will meet the needs of our diverse populations. And I think as a health plan, it's difficult for us to create plans and products that serve as marginalized communities where we're not able to develop those plan and benefit designs that are focused on them. And what I mean by that is our ability to deploy a Spanish-first diabetic plan that's focused on the Spanish population and their unique needs around diabetes, or our abilities to focus on the African American female population through plan and product design and focusing that community related to maternal health services. And so if we think about what our population looks like today and what we expect it to look like tomorrow, it's going to continue to be very diverse. And our ability as an insurer to be able to provide plans, products, and benefit designs that are personalized is going to require that we have legislations and opportunities to offer, I think, a variety of products that meet the needs of the consumer.
So I'm going to say this. This is going to be for Irene and for Lina. So you guys listen, ladies. I don't want to get back and interrupt the flow of the conversation after that. But really thinking about the point that you just made, Tamara, around give us the data and we'll figure it out. That is part of Oscar's secret sauce, right? Really being technology powered and technology forward. But even with that, you're saying you need the right data and the right metrics. So Irene, I'm interested and would love for you to share some of the things that you think in your expertise are the most helpful data elements and intriguing metrics that could really inure to being important for improving and advancing towards health equity. And then Lina, I think that listening to how Dr. Irene answers this question and also just gleaning from your experience, contemplating some of the ways that laws and regulations may impede either employers or others, both getting these metrics and the data and then using them for benefit design purposes and other purposes that are related to improving health equity.
That's a great question. Definitely the data and metrics will depend on the health outcomes that you're trying to achieve, right? The health equity outcomes, because there's so many categories. I would give, so I joined Marti Health, which is a digital health equity startup company, as well as care coordination. We are focusing on patients with sickle cell disease and providing that sort of special needs, value-based care, working along with community, the community and the sickle cell advocacy groups. And why sickle cell disease? Because if you see one patient living with sickle cell, you've seen just one. And this is a group that, to me, in my opinion, suffers the most. First of all, they call themselves warriors, which they are. They were born with a disease that relegates them to a shorter than average lifespan because of that genetic mutation. They also subject to a healthcare system that has a legacy of structural discrimination against them, right? And so when they're in the emergency room, they are seen as adults, they're seen as drug seekers because they have a life of chronic pain from the sickle cell disease. But these are the same hospitals and ERs that would readily give them, pain control when they were kids. But when they reach adulthood, these same hospitals will, consider them as frequent flyers and pain drug seekers. And they have we have very few specialists that treats patients with sickle cell. We have very limited research on sickle cell. or clinical trials for that matter. So when we're looking at health equity metrics and outcomes, especially in this era of precision medicine, every single data is important. And so what we're doing is we engaging them in collecting data, not just within the hospital system or the ER, but also in their environments along with their caregivers. So the metrics there will be quite different, right? Because what we've asked them is, and we engage in the Marti Health app where we ask them, what are your health goals? Because we want to make sure that we are providing care to them to achieve health equity, which means, optimal care, quality care for them. So in terms of data and metrics, I would say that it's all dependent on the patient population, but the goal will be to try to achieve quality care and equitable care that's personalized for each of the population groups. So I think that's what I really wanted to say. And sadly, I would say that every health equity intervention needs to come with an appropriate budget. You cannot just set metrics and goals and objectives when you have limited budget or resources, because it's important that you have a budget that's adequate. It's important to have metrics and goals that are, relevant and reliable and timely. SMART goals is what I mean. But this certainly we should be thinking about the kinds of data that are needed to really achieve that optimal health, so that that patient or population can function well in society and meet their healthcare goals.
Great. And I think to build off of that, so in the federal government's perspective, right, like we collect data, and then I think, we were talking earlier about like what can we share. So I think in a lot of places, CMS broadly has tried to put more data out there. And I forgot to mention earlier on, I think some things that this administration's looking at, which maybe previous ones didn't at our level, is social determinants of health. There's a sickle cell disease action plan that we recently put out, focusing on class standards. Those are some of the initiatives that I think our agency has been super focused on. So in that realm, for example, we have a MMD Medicare tool, which we recently just added information on social determinants of health. We also added information specific to sickle cell disease as well. And so we are trying to build out fields for that data. And so I think that's a useful area for input, where we try to get input from others in terms of what would be the most useful to researchers and providers and others, as we have that opportunity to do that. There are other places, though, where we cannot share as much data. So I think in the EDGE data that I talked about earlier, that is claims data, and there are certain rules, in statute and the like, for our ability to be able to share that. They are still, however, really good tools for us to ingest and be able to make policy decisions that are more informed by who we have enrolled in coverage. And then I think as we think about kind of data, so in an ideal world, I talked about, the race ethnicity data that we're kind of struggling with and wish we had more of. Oscar has, I don't know, I wrote down the stat, 80%. Yeah, I wrote it down. So like there's different ways to think about partnerships that I think we're open to and would love a dialogue here about as well, in terms of, are there opportunities to collect that data from issuers back to CMS, vice versa? How can we kind of better inform those? And I think some states have done some interesting things, kind of thinking about your contracts with your carriers and how can you use that as leverage for kind of additional requirements. So folks have thought about that in sort of quality metrics, almost like goals for the carriers in terms of having race ethnicity data completion. That's one avenue. I know at the CMS level, we required culturally and linguistically appropriate methods as part of their training for agents and brokers enrolling people in care. And QHP issuers have contracts with their agents and brokers, and they can go further than we are in that sense too. So I think it's all about each of us has different roles to play and different authorities, and there's different ways to kind of leverage those going forward for additional exchanges of data to make them more productive. But I think generally, to the extent we can, across CMS, we try to have these nationwide tools so that they are resources to folks and researchers and others to be able to do more.
Yeah, I just want to add that we also need to make sure that if we collect the data and we really, the goal is health equity, like if we collect race and ethnicity, we need to track the outcomes by race and ethnicity. We need to track outcomes by, geography and because sometimes we just collect it.
Yeah.
And then the next step in terms of tracking by race and ethnicity is it's not achieved. So part of achieving health equity is really tracking along these lines as well.
Can I add to that and build off the discussion? So I think we're all for collecting data, right? If you don't get data directly from the patient, data in itself could become a weapon or not accurate. And so what I mean by that is zip code data could be deceptive. You have to make certain assumptions, and your assumptions could be biased and wrong, who lives in a particular zip code. Using last names is another great example of indirect data. A last name, you may use stereotypical assumptions about someone's last name. So when you think about data and enhancing data, you also have to be thinking, how do I get that direct data from the patient, from the member, and not from the physician's office, because sometimes the physician makes incorrect assumptions about you. So I just wanted to put that out there, not as a naysayer, but as just be realistic. If you don't have direct data, be realistic about the indirect data sources that you're using to make certain decisions. The other point I think is worth underscoring, and Dr. Irene and the panelists from Oscar mentioned all of this, is bias, and bias that we all have, but also in technology. And one tool that employers and health plans all have is the provider contracting tool. And so to require your network providers to have bias and cultural sensitivity training could actually go a long way. And I want to build off the sickle cell example. We heard from one of our health plans an actual case. A black male went to the emergency room, and the ER doctor treated that black patient for a drug overdose. The black patient had a severe episode of sickle cell. And so that's what bias looks like. So one way to address that bias is through good training. Now, obviously, training is now going to weed out intentional behaviors, but training, understanding microaggressions and how we view the world, how we've been taught to view the world, could really help clinicians understand their patients better and treat them better. And Dr. Lisa talked about this earlier as well, humility, but all of that requires the right training. So requiring that as provider contracts, that's one way to get at that. The other point I wanted to make about bias in technology, and take it further to say, and it takes 10 years for a standard of practice for clinicians to change. Great example is EGFR. How many people know what that is? Some of you, okay. So kidney test, and so used to have a race bias. So if you or your doctor said you're black, you got extra points on your blood test for kidney function, and that meant it made you look healthier than your kidneys actually are. And you got delayed getting your kidney transplant, your dosing for medication was incorrect. And so the National Kidney Foundation changed all that, but not all labs changed the test. So the algorithm they're still using, some of the labs in the US have the race adjustment that continues to perpetuate these bad outcomes we want to change. So through provider contracting, you can actually require your labs to use the new standard.
I want to make one comment to what you shared as it relates to how we use data that I think is very important for the folks in the room. We're going to get a lot of data from a lot of different places, and it's going to tell us a lot of different things. And what I think is very important is that we spend the time to speak to the communities that are impacted by this data to ensure that our interpretations are accurate. And so as we develop plans and benefit designs within our organization, if we're deciding to build something, let's say, innovative for our Spanish-speaking population, we go to our Ola Oscar ERG within our company because we want to make sure that we are meeting the needs of the people that we serve and hearing from them directly to make sure that our ideas and our intent are on par with what their expectations are. And so as we continue to drive innovation and reduce the inequities that we see, I would just challenge the folks in this room to continue to go back to the communities of whom we're trying to solve for and make sure that what we are moving forward with is on par with their expectation and is culturally sensitive and appropriate.
So we're going to solicit questions from in the room and anyone who may still be on the online option. And I just kind of want to, in the segue to that, summarize what I've heard these expert panelists talk about, which is sort of this stair step to the implementation of data and technology as a tool to advance towards health equity. And I think the important thing is to note at the ground level, the thing that really feeds everything in this space is trust and understanding. It's understanding the deficiencies in the system that we have currently, and trusting that, you know, the patients themselves can tell you if you also understand that they are people first and not cogs in a wheel. And I know sometimes my background is in health insurance as well. Sometimes we depersonalize the people at the center of healthcare. Right above that is thinking about, like, these things are barriers. Do we have affordability for people to access? And do we have clinicians to deliver care for people to access? And in both of those spaces are the affordability points and the clinician adequacy points, things that we're contemplating. We can't 3D print clinicians, but we can do things to make sure, for example, as Mila alluded to, the tools that we have to train up, upskill the clinicians that we have are done so regardless of whether it is happening from the point of medical education or it's happening from the professional side. And then also just thinking about data and metrics at the top. Data is king. We are in a data-informed world, and we have to really make sure that we are, with clear eyes, taking the data that we have, running it through our algorithms and our tools in a way that really serves the need and thinks about what are the outcomes that we want to achieve. And I think the one thing that I would leave with everybody as we go to Q&A is we really can't boil the ocean with health equity. We can't mitigate hundreds of years of disinterest in serving the population equitably, both by rurality, gender, race, ethnicity, language, and other points of culture. And so really thinking about, you know, tackling things in a prioritized way and remembering that if you make one, you know, stride, you make a stride, and then you go and tackle the next one. And then we fight another day, because that's healthcare in the U.S. So are there questions?
Yes, we have a question from our virtual audience. It was mentioned that legislative action will be required to create better plan and benefit design. For our panelists, if you're able to, can you say more about what types of legislative or policy action you'd want to see?
Yeah, I think, can you hear me okay? Mm-hmm. Good. I think the current legislation's intent on limiting plan and product designs was intended to really simplify the choice for members, you know, to make things less difficult, less confusing as folks went out to purchase healthcare insurance for the affordable exchange, of which I can fully appreciate. However, in limiting, I think, the optionality for consumers from having, I'd say, unlimited options to now having 2 to 4 options, it forces insurance companies to generalize. And so if yesterday I could provide you a specific option for a Hispanic member that has diabetes, a specific option for a African American member that has maternal health challenges, a specific option for a Vietnamese member, we no longer have that optionality. And so I think as we look to, move forward additional legislation around what's needed from a healthcare reform perspective to create the purchasing experience that is easier for people to understand. I'll go back, I think, to the keynote earlier, and that I think there are inroads that we can make as insurers in a place that Oscar has focused on really ensuring that the information and the content that we put out is easy to understand. That the onus is on the insurer in partnership with the federal government to ensure that that purchasing experience is one that's easy for someone to navigate. We have a product today that we've deployed for our diabetes plan, and right now 30% of our membership is Spanish speaking. We also deployed a new product that is focused on our Hola, we call it Hola Oscar, but our Spanish-speaking population. So imagine being able to combine the end-to-end experience for a Spanish-speaking member that is country of origin specific, along with addressing their specific disease state, is something that's extremely powerful. And what we found is that for that cohort of the population, they appreciate it. And our Net Promoter Score is 84 for that cohort in particular, because we're speaking to them in their native language. We're speaking to them in I think what the team called plain language, and it's easy for them to understand. We're wrapping around care teams and concierge teams that also speak in their native language in a way in which they can understand. And then we're setting up clinical programs to support their specific disease state. And I remember when we were in the process of developing this product and we went to our employee resource group internally and said, hey, give me some feedback. And I remember a team member saying to me, I'm Puerto Rican and she's, from Honduras. We're different. Our social norms are different. Our cultural norms are different. How we interact with insurance and our expectations are different. And it was eye-opening, and it helped us kind of dig even deeper to figure out how can we personalize our products even more than what we do today. And so we have, I think, a pretty exciting yet radical desire to continue to do more of that. And we want to make sure that we can partner with the right agencies to help us in better activating more personalized care, but in a way that makes it easy for people to understand and easy for people to sign up for.
And I just want to add to what Tamara just said. For us, the biggest barrier to equity-based benefit design is the four metals, the four designs that Tamara mentioned. The AV calculator, it's a concrete wall. We are exploring waiver through 1332, but that may not be realistic for us. So, and I'm not sure if regulatory authority exists within the federal government. It may require legislative flexibility. The other big area for us that we're looking for HHS to move forward on is the proposed 1557 non-discrimination regulations, which actually include addressing the clinical bias that continues to exist in current medical clinical guidelines. So we hope that the Biden administration finalizes those as proposed, because that will help address a lot of the bias and systemic racism and discrimination that continues to exist for many communities we serve.
We definitely will work on that. We definitely should. I also just want to say, let's think more about equitable health benefits, as you hear, and underlining it, and not equal health benefits. So,
I think that's a mic drop
Thank you.
moment. So thank you all for your attentiveness and your engagement, and thanks to the American Academy of Actuaries for hosting this very important day. Can we give that team a round of applause for this conversation? And our excellent closing panel. Thanks so much.